We will discuss today gum, teeth, and jaw from the surgical aspect. At first, we will discuss the swellings of the gum. The swelling of the gum is called epulis. Epulis have multiple types. We have fibrous epulis, myeloid epulis, and granulomatous epulis, sarcomatous epulis, and carcinomatous epulis. So, epulis is the swelling of the gum. The first type is the fibrous epulis. Fibrous epulis is a fibroma of the gum, mucoperiosteum of the jaw. It raises near the incisors teeth of the lower jaw. It's usually small, painless, pedunculated swelling. Doesn't cause wide separation of the teeth, white pink in color, and doesn't bleed easily. The treatment is extraction of the tooth in both sides and then wide excision of the tumor. Why wide excision of the tumor? Because it may change into sarcomatous epulis. It may change into sarcomatous epulis. So, fibrous epulis is a fibroma of the gum, raises from the mucoperiosteum of the jaw, pedunculated mass, doesn't cause wide separation of the teeth. Its treatment is extraction of the both teeth and wide local excision. Why wide local excision? Because it's changed into sarcomatous epulis, sarcoma, malignancy. The second type of epulis is a myeloid epulis. The myeloid epulis is the osteoclastoma of the gum. Osteoclastoma of the gum, erasing from the bone. It's occur mainly in the lower jaw, painless lobulated sessile mass, cause wide separation and losing of the teeth. Unlike the fibrous epulis doesn't cause wide separation, while myeloid epulis cause wide separation and may lose the teeth. It's highly vascular, purple in color, unlike the fibrous epulis white pink in color, less vascular. Myeloid epulis cause serious bleeding, massive bleeding when it opened, unlike the fibrous epulis. Treatment is wide local excision with safety margin may reach to hemimandibulectomy. Hemimandibulectomy because it's osteoclastoma. Osteoclastoma, tumor of the gum. Again, myeloid epulis is the osteoclastoma of the gum. Osteoclastoma of the gum, while fibrous epulis is the fibroma of the gum. Myeloid epulis raises in the lower jaw. Also, fibrous epulis raises in the lower jaw. Painless lobulated mass. Fibrous epulis is pedunculated mass. Myeloid epulis, purple in color due to high vascularity, while fibrous epulis, white pink in color due to less vascularity. So, fibrous epulis doesn't bleed easily, fibrosis, while myeloid epulis have a serious bleeding. Both is treated by wide local excision. Wide local excision. The third type of the epulis is the granulomatous epulis. Granulomatous epulis, mass of granulation tissue adjacent to a caries tooth. It's caused by a caries tooth. Small lobulated mass, devoid of epithelial covering, red in color, bleed easily. Treatment is extraction of the cause, the caries tooth, and the excision of the granulation tissue. The fourth type of the epulis is malignant epulis. اللي هي sarcomatous epulis which raises from on top of fibrous epulis as we said. It's a periosteal fibrosarcoma. Sessile mass fixed to the bone, bleed easy on touch, unlike the fibrous epirus, with loosening and widening of the teeth. Wide local excision with safety margin is the treatment of malignancy. Hemimandibulectomy may be done. Carcinomatous epirus, carcinoma. What's the difference between sarcoma and carcinoma? Sarcoma arising from the connective tissue, while carcinoma arising from the epithelium. So, carcinomatous epirus is the epithelioma of the mucous membrane of the gum. As we said in the last lecture, epithelioma is the squamous cell carcinoma. So the carcinomatous epirus is squamous cell carcinoma of the mucous membrane of the gum. The mucous membrane of the gum is lined by stratified squamous epithelium. What's the malignancy of the stratified squamous epithelium? Squamous cell carcinoma. So carcinomatous epirus is the squamous cell carcinoma. Squamous cell carcinoma, the most common presentation is ulceration. Ulcer, raised everted edges, indurated base, necrotic floor, and indurated base. As we said in the last lecture, squamous cell carcinoma. But carcinomatous epirus is the squamous cell carcinoma of the lip. Treatment of the squamous cell carcinoma is wide local excision with safety margin of the and maybe mandibular reconstruction with block neck dissection if needed. If there is a palpable lymph node, block neck dissection in the squamous cell carcinoma. Block neck dissection even without a lymph node, without palpable lymph node. Block neck dissection is required in all cases. Radiotherapy has no role in the carcinomatous epirus. So the epirus is the swelling of the gum. Epirus is the swelling of the gum. This is the most important item. MCQ question: the swelling of the gum is called epirus. The common MCQ question: swelling of the gum is called epirus. What's the types of epirus? Fibrous epirus, myeloid epirus, granulomatous, sarcomatous, carcinomatous epirus, which is the epithelioma, squamous cell carcinoma of the gum. The swellings of the teeth remnants. Our lecture is about the gum. So this is the gum. Teeth, the swellings of the teeth. We are not concerned about the teeth itself. We talk about the surgical aspect of the teeth. What is important for us in surgery is the odontomes. Odontomes is the teeth remnant swellings. Teeth remnant swellings is called the odontomes. Odontomes, swellings raising from the dental epithelium. So epirus is a swelling of the gum, while odontomes is the swelling raising from the dental epithelium. We have epithelial odontomes like dental cyst and dentagerous cyst, adamantinoma. Swellings raising from the connective tissue of the teeth is called cementoma. There is composite odontomes which raising from the connective tissue and the what's the odontomes? Odontomes is the cystic tumor raising from the dental structures, from the dental structure, epithelium or connective tissue. So odontomes is the swellings of the dental structures, while epirus is the swelling of raising from the gum. Odontomes may reach from epithelium, dental cyst, dentagerous cyst, adamantinoma, or maybe connective tissue like cementoma, or maybe composite odontomes, epithelium and connective tissue. We will discuss first the dental cyst. What's the dental cyst? A dental cyst is cyst caused by chronic irritation of the paradental epithelium debris of maliceasis by nearby infected tooth, usually the incisors or canine. There is an infected tooth, dental caries, usually the incisors or canine tooth, chronic irritation of the paradental epithelium by this infected tooth leading to formation of the dental cyst. It's commonly in the upper jaw, especially in the anterior part. Unilocular cyst slowly growing, expanding the jaw in the both sides, inwards and outwards, lined by squamous epithelium containing mucus fluid, high rich in cholesterol. So, dental cyst is due to chronic irritation by infected tooth. Its unilocular cyst expand inside the mouth and outside the mouth, lined by squamous epithelium, has a mucoid fluid rich in cholesterol. It's common in the adult life due to common caries in the adult life. Painless, slowly growing swelling in the anterior part of the upper jaw with eggshell crackling sensation. Eggshell crackling, the eggshell crackling sensation due to thin bone. Investigation may be required plain X-ray showing a well-defined cyst, which is empty. The cyst has no teeth inside. Treatment: extraction of the infected tooth and opening the cyst through the gum, curettage of its contents following by crushing of the alveolus of the tooth. This is the dental cyst. What's the dentagerous cyst? Dentagerous cyst is due to cystic degeneration of a dental follicle. It's raised in the lower jaw in relation to an erupted tooth. Dental cyst is related to the infected tooth, while dentagerous cyst is related to an erupted tooth, especially the third molar tooth. It's commonly raised in the lower jaw in relation to an erupted tooth. The cyst contain maldeveloped, maldirected tooth filled with viscid fluid. It grows to outside, causing a thinning of the outer table of the jaw, and there are ridges in its wall, pseudotrapecally. It's common in the children and the adolescents, unlike the dentagerous cyst. Painless swelling near the angle of the jaw with eggshell crackling sensation due to thin bone, and there is in the X-ray maldirected tooth, and due to trapecally give the soup pupils appearance. The soup pupil appearance. The treatment is deroofing of the cyst, removing of the tooth, curettage, and crushing of the alveolus. And this is a comparison between the dental cyst and the dentagerous cyst. Dental cyst is related to erupted tooth under its root but is infected, while dentagerous cyst over the crown of an erupted tooth. Dental cyst causes complication like osteomyelitis. Dentagerous cyst may turn to locally malignant tumor, adamantinoma. Treatment: excision and extraction of the tooth, while dentagerous cyst treatment is opening of the cyst, which is called the marsupialization, excision of the unerupted tooth, and the curettage, crushing of the alveolus. This is the difference between the dental cyst and the dentagerous cyst. Again, dental cyst raising in relation to infected tooth, while dentagerous cyst is related to an erupted tooth. The dentagerous cyst is a dental cyst raises in the upper jaw near the incisors or the canine tooth, while the dentagerous cyst in the lower jaw and in relation to its angle. Dental cyst in the X-ray, it shows a well-defined cyst which is empty, while dentagerous cyst is a cyst which has a tooth inside it and trabecally giving the picture of soup pupil appearance. The treatment of the dental cyst is excision and extraction of the tooth, while the treatment of the dentagerous cyst is marsupialization, excision, and then extraction of the tooth. The third type of the odontomes What's the odontomes? Odontomes is the swellings related to the dental structures, maybe epithelial like dental cyst and the dentigerous cyst and adamantinoma. We talk about dental and the dentigerous cyst. Thirdly, we will talk about the adamantinoma. Cysts related to the connective tissue like cementoma, which is rare in men, and composite odontomes. So adamantinoma is the third type of the epithelial odontomes. Adamantinoma is a basal cell carcinoma of the paradental epithelial debris of mellitus. And the basal cell carcinoma is a locally malignant tumor. We talk about basal cell carcinoma in the last lecture. Basal cell carcinoma is a locally malignant tumor. What's the meaning of the locally malignant tumor? It's a malignant tumor without distant metastasis or without lymphatic spread. So adamantinoma is a locally malignant tumor, basal cell carcinoma of the paradental epithelial debris. Paradental epithelium, the epithelium which is related to the tooth beside the dent, besides the tooth, paradental epithelial debris of mellitus. It's commonly in the lower jaw near the angle, like the dentigerous cyst. We say that the dentigerous cyst may turn to adamantinoma, which is a complication of the dentigerous cyst. So it's also commonly in the lower jaw near the angle. Like this picture, the black arrow directed to the adamantinoma, which appear in the lower jaw near the angle. Like the dentigerous cyst, it's a multilocular cyst with a trabecule, but containing a brownish mucus fluid with thinning of the outside of the mandible, grows forwards in the body and upwards in the ramus of the mandible. What's the complications of the adamantinoma? Maybe bleeding, ulcerations, losing of the teeth, recurrence after local excision, and malignant transformation. Maybe malignant, not alone becoming malignant, become a malignant transformation. Ulceration or infection, and the bleeding, falling of the teeth with pathological fractures. It's common in young adult females, 25 to 45 years. Also, it's like the dentigerous cyst, painless swelling at the angle of the mandible, which is hard in consistency with possibility of eggshell crackling sensation like a dentigerous cyst, maybe losing of the tooth and ulceration of the gum, maybe enlarged lymph nodes due to secondary infections. Plain X-ray show multilocular cyst with subpapal appearance or honeycomb appearance with equal lobulation. Unlike osteoclastoma of the mandible. The osteoclastoma of the mandible, an equal loculation, giving fine coarse subpapal appearance, while the adamantinoma, multilocular cyst with equal loculation, giving fine subpapal appearance. The differential diagnosis of adamantinoma is the osteoclastoma. The osteoclastoma occur near the symphysis mentae, near the midline, while the adamantinoma near the angle. يبقى adamantinoma near the angle of the mandible, mass near at the angle of the mandible, while osteoclastoma near the symphysis mentae. The spread of the adamantinoma horizontally and vertically, while the spread of the osteoclastoma is horizontal only. Stop at the angle of the mouth, not reach the ramus of the mandible. Adamantinoma reach the ramus of the mandible. Adamantinoma cross the midline, while the osteoclastoma doesn't cross the midline. Adamantinoma, like the dentigerous cyst, grows more in the outer side, while osteoclastoma grows in the inner and outer sides of the mandible. As we said in the X-ray, adamantinoma multilocular with equal loculation, while the osteoclastoma unequal loculation. This is the difference between adamantinoma and osteoclastoma. Osteoclastoma in the symphysis mentae, while the adamantinoma, the angle of the mandible. Adamantinoma grow in the both vertical and horizontal directions and merely cross the midline, while osteoclastoma in the horizontal only stop short out of the mandible angle and never cross the midline. Adamantinoma grows in the outer side, while osteoclastoma grows in the both sides. Adamantinoma X-ray multilocular with equal loculations, while osteoclastoma is multilocular with unequal loculations. This is the picture of osteoclastoma. This is a picture of the swoop bubbles appearance, multiloculation cyst with multiloculation equals loculations. Note the separation of the tooth and losing of the tooth, and separation of the tooth in this picture of the adamantinoma X-ray of the adamantinoma. What's the treatment of adamantinoma? Resection of the affected segment of the mandible with a safety margin at least half an inch, and replacement of the mandible by a bone graft or artificial prosthesis. Again, adamantinoma is the basal cell carcinoma of the paradental epithelial debris. It's commonly at the angle of the mandible, like dentigerous cyst. It's a growth in the outer side of the mandible, leading to thinning of the bone, may be complicated by losing of the teeth, ulceration of the gum, bleeding, malignant transformation, and recurrence after local excision. It's painless swelling at the angle of the mandible, like in this picture, maybe secondary lymph node enlargement due to infection, brain X-ray, swoop bubble appearance. Note the losing of the tooth with equal loculation. Adamantinoma rising from the paradental epithelium, while osteoclastoma rising from the bone. What's the difference between adamantinoma and the osteoclastoma? Osteoclastoma near the symphysis mentae, while adamantinoma at the angle of the mandible. Adamantinoma may expand to the ramus of the mandible, while osteoclastoma doesn't cross the midline or doesn't cross the angle of the mandible. Adamantinoma in the X-ray equal loculation, while osteoclastoma unequal loculation. Treatment of adamantinoma is removal of the affected segment of the mandible and reconstruction by a rip or by a prosthesis with a safety margin at least 1.5 inch, at least half inch. Through tumors of the jaw, we have true tumors of the jaw rising from the jaw itself. Tumors of the jaw itself. Maybe ovary osteoma raises from the bone developed from the membranes at the ramus of the mandible. Calcaneus osteoma, which is called osteoid osteoma. Giant cell tumor osteoclastoma. We talk about the osteoclastoma in the adamantinoma. It's a true bone tumor, not rising from the paradental epithelial debris. True bone tumors. Sarcoma of the jaw, like osteosarcoma, fibrosarcoma, and Burkitt's lymphoma, and secondaries of the secondaries from the oral cavity or from the cancer lab or from the salivary glands. So we can classify the bone tumors of the jaw into benign tumors like osteoma, either ovary osteoma or calcaneus osteoma, locally malignant tumor like osteoclastoma, malignant tumors like sarcoma, and secondaries like sarcoma and secondaries. This is the tumors of the jaw. Cancer maxilla. Cancer maxilla is a cancer of the mucous membrane of the lining antrum, palate, gum, and teeth stalk. the maxilla. Pre-malignant condition of the cancer maxilla is chronic maxillary sinusitis. It raises commonly from the antrum of the maxilla. Microscopic picture is a fungating mass. Maxilla is the cavity, the paranasal sinus, which is the cavity. This cavity mass rising from the mucous membrane. This mass is a fungating mass. Microscopic picture adenocarcinoma, which is most common, rising from the antrum, while squamous cell carcinoma rising from the palate, gum, teeth, and stalks. Adenocarcinoma rising from the antrum, and squamous cell carcinoma rising from the palate, gum, teeth, stalk. Spread may be direct spread to the surrounding structures or lymphatic spread to the upper and deep cervical lymph nodes. Blood spread is rare. What's the complications of the cancer maxilla? Cosmetic disfigurement, distant metastasis, and encroachment to the surrounding structures. What's the presentation of the cancer maxilla? Cancer maxilla patient may be of both sexes, may be male or female, age above 40. The earliest presentation of the cancer maxilla is sinusitis, chronic sinusitis, which is not responding to the ordinary treatment with nasal discharge, which is bloody nasal discharge. So the patient of the cancer maxilla have the presentation of chronic sinusitis with bloody nasal discharge. Bloody nasal discharge. This chronic sinusitis not responding to the ordinary treatment. So if a patient more than 40 presented to your clinic by chronic sinusitis who may be discharged with usually bloody discharge, not responding to the medical treatment, usual medical treatment, we must suspect the cancer maxilla. The later on presentation of the cancer maxilla is due to spread to the adjacent structures, extension anterolaterally to the cheek, leading to fungating mass in the cheek, and which is ulcerate. Extension to the medial wall leads to nasal obstruction and epistaxis, and epiphoria due to nasolacrimal duct obstruction. Extension to the roof of the maxilla leads to proptosis. The roof of the maxilla is the eye, proptosis and diplopia, and finally loss of vision. Extension to the floor, depression of the hard palate, and maybe fungating mass from the mouth. Extension to the posterior wall leading to obstruction of the nasopharynx and cranial nerve palsy. Enlargement of the cervical lymph nodes may be the earliest presentation of the cancer maxilla. So, the earliest presentation of the cancer maxilla is chronic sinusitis, not responding to the medical treatment, and nasal discharge, which is maybe bloody. Extension of the fungating mass to the related structures of the maxilla, to the roof of the maxilla, which is the eye, leading to eye symptoms like proptosis, diplopia, and loss of vision. Extension to the mouth, fungating mass in the mouth, and maybe bleeding in the mouth. Extension to the back, to the nasopharynx, obstruction and cranial nerve palsy. Extension to the medial side of the maxilla, which is the nose, leading to nasal obstruction, epistaxis, and epiphoria due to nasolacrimal duct obstruction, palpable cervical lymph nodes. What's the investigations of the cancer maxilla? CT scan is the investigation of a choice for detection of the cancer maxilla. Detect the size, extension of the tumor, and the lymph node metastasis. Biopsy from the mass by endoscopy or exfoliative cytology from the discharge. This is called exfoliative cytology. Fine needle aspiration from the discharge or lavage of the antrum. Fine needle aspiration from the lymph nodes. Differential diagnosis of other swellings of the jaw, as we said, especially sarcoma of the maxilla, in which sarcoma is younger age group, rapidly growing, leading to short duration, وبين is early metastasis. So sarcoma, which rising from the bone of the maxilla, not from the mucous membrane like the carcinoma, occur at younger age group. Rapid rate of growth leads to shorter duration, وبين is early with early metastasis. What's the treatment of cancer maxilla? Maxillectomy, total maxillectomy and replacement with maxillary prosthesis to avoid facial deformity. Block neck dissection of the cervical lymph nodes. In late cases, radiotherapy. This is the cancer maxilla. Again, cancer maxilla rapidly, the cancer rising from the mucous membrane of the maxilla, mucous lining of the maxilla. Maybe adenocarcinoma in the antrum, maybe squamous cell carcinoma in the palate, gum, teeth, stalk. It's usually presented by a fungating mass, like any other tumors, is spread direct to blood spread or lymphatic spread. Complications is mainly due to encroachment of the adjacent structures, the iris presentation, chronic sinusitis not responding to the treatment with discharge from the nose, which is usually bloody discharge, extension to the surrounding structures, the roof, floor, medial side, lateral side of the maxilla, affection of the related structures like the eye, nose, nasopharynx, palate, extension to the lymph nodes. The investigation of choice, CT scan and MRI for detection of the tumor site size and extension and lymph nodes metastasis. Biopsy piecemeal from the mass. Differential diagnosis, carcinoma of the maxilla, sarcoma of the maxilla, which is from the bone, rapidly growing younger age group with early pain, with early metastasis. The treatment is total maxillectomy and replacement with maxillary prosthesis to avoid the facial deformity with block neck dissection of the cervical lymph nodes. Late cases, advanced cases, combined radiotherapy and surgery. Thank you.